I think we'll kick off today's presentation. So good morning, everybody. My name is Boris Vilgorin, and I'm the healthcare in, excuse me, and I'm with the McSilver Institute and MCTAC, the Managed Care Technical Assistance Center. I am happy to say that I'm joined by a number of our OMH colleagues and my colleagues from MCTAC as well. And today's presentation, just to make sure we're all in the right place, is around reimbursement for services provided by OMH licensed school-based mental health outpatient treatment and rehabilitative service programs. Okay, MHOTRS. And we're excited to have you all again join us. We have a decent amount of information to share with you. Today's agenda is really divided into two parts. One, we're going to talk about the MHOTRS rate enhancement, and we'll cover things like program allowance, billing considerations, and so forth. And the other part is the commercial insurance reimbursement, again, for MHOTRS billing process, partnering with plans, and some of the next steps that you can take. We are recording today's presentation. The slides and the recording will be made available. We'll be posting both on our MCTAC website. We're also going to be sending out an announcement when that becomes available. It might not happen till a couple of days or maybe early next week, but we are going to make both the recording and slides available for everybody. And we also would encourage folks to chat in their questions. Throughout the presentation, we also put some time aside at the end for discussion and additional questions. But again, as we go through this, if there's things that are coming up that you would like to ask or comments, we would appreciate that you share those with us as we go through this presentation. So without further ado, I think I'm going to be transferring over to Shannon, who will start on the rate enhancement.
Thanks, Boris. Hi, everyone. Good morning. Thanks for joining. I'm Shannon Fortran with the Office of Mental Health. I am the Unit Director for Children's Outpatient Services. I'm also joined by another OMH colleague, Gwen Diamond, who will have an opportunity to also introduce herself in just a few slides. So I'm going to talk about, hopefully nothing that's new news to you, about the rate enhancement specific to school-based MHOTRS programs. I'm going to functionally refer to it as clinic, but obviously referring to MHOTRS. Next slide, please. Okay, so I think not new news to anyone, hopefully, on this call. There's unique features obviously inherent to partnering with a school district that this rate is intended to recognize. Right, speaking on, programmatically anyway, the partnership, right, the coordination and collaboration, some coordination is inherent to any mental health service, but the extent to the amount of coordination that's needed when partnering with school personnel is just a unique feature and an ongoing feature, right? Not just at the practitioner level, but also at the admin level. But then there's also other unique features, right? There's unique startup elements, right? Usually a fixed population in which to build a caseload when establishing a satellite. So, preaching to the choir on those things, but these are all elements that are typically non-billable or take time to ramp up for fiscal viability. So recognizing these unique features that are inherent to a school-based satellite is the justification for the 25% rate enhancement. So there was last year an update to the billing guidance. It's hyperlinked here. Hopefully you've all had an opportunity to look at it. There was a section that was added to the actual body of the guidance, but then the more programmatic information around the billing allowances is actually in the appendix. So in case you didn't see that reference, that's where you can find the more specific information. So as I said, the rate enhancement is a separate rate code reimbursing at 125% of a non-school-based satellite clinic on-site rate. It is exempt from utilization threshold, and the second service does have that 10% discount that still applies. So hopefully not new information, but a nice opportunity today to walk you through this update. Next slide, please. Okay, so this is the information that I was referencing that's in the appendix section. So we tried, to be as flexible as possible with regulatory allowances specific to school-based satellite clinics. So these are a brief summary of the allowances. So if you want just a little bit more detail, it is in the billing manual, as I said. So these are the circumstances in which that 25% rate enhancement can apply. So I think in person is pretty intuitive, right? When services are delivered on site, in person, via the satellite, and it aligns with operating hours, so OC, hours of operation and approvals, those are applicable and can be billed under that 25% rate enhancement. It also does apply, which we'll get into a little bit with telehealth, but it does apply to services also not captured on the OC. So if services are delivered through the main clinic, but they're facilitated through the satellite for a satellite enrolled student, like peer services, like med management, the rate can apply because we're recognizing, right, there's a level of coordination that is still occurring to serve that student that's enrolled in the satellite. As far as telehealth allowances, there are a few circumstances in which it is permitted. Obviously, telehealth, this all is predicated on standard telehealth allowances. So you'd still have to be adherent to provider guidance for telehealth. But when a student is enrolled in the satellite for ongoing, routine, on-site service provision through that school-based satellite, that's when these telehealth allowances would kick in for billing under the 25% rate enhancement. So that doesn't mean that you can't bill routinely, right, the base rate, but for the 25% rate enhancement specifically. So when services are delivered by appointment, so outside of OC hours, if your operating certificate says your standard hours of operation, and then there's the caveat that says or by appointment, so then you can bill for telehealth outside of your OC hours. So a good example of this is, say your OC says you can provide services, let's say 8 a.m. to 3 p.m. But then a family session, it is maybe more convenient at 6 p.m. and that's by appointment, right? And the family can't make it into the school, the satellite's not open during that time, so you can provide a telehealth session for that by appointment session. Another billing allowance for telehealth is when the practitioner, the treating practitioner that's assigned to that satellite is off-site during hours of operation, but there's another clinic staff on site that can facilitate that telehealth session for the student. So, there's a stipulation that a clinic staff member must be on site during the hours of operation, not necessarily that it has to be the treating practitioner. So if the treating practitioner is maybe at the main clinic on that day, but there's another staff that is at the satellite to furnish the telehealth session for the student and the practitioner that's offsite, that is permitted. Another example is similar to the in-person example, is when there are services provided that are not part of the satellite via the main clinic. So if the student needs med management, if they need testing services, peer support services, when it is facilitated through the satellite, that is also billable under the enhanced rate. And then the last allowance is for circumstances in which the student is temporarily remote. So maybe medical reasons, suspension, whatever the case may be. But I think the thing that we need to underscore there is that it is a temporary situation in which telehealth can be applied in that circumstance.
All right, Shannon. You started something here because the chat is not exploding, but it's busy. Let me just put it this way. So let me, I think some you kind of answered as questions were coming in, but let me maybe, and I don't know, I'm be curious to know how many people know this, but we'll do a little bit of an Abbott and Costello routine here. But anyway, so let's go back to the in-person and just make sure I'm following you along. It's clear, like you have a satellite clinic at school, I'm there as a clinician, so, the family comes, I see them, that's an enhanced rate within operating hours. That's clean, right? That's kind of the, but then I also say, hey, you might benefit from medication. We don't have medication management here, or psychiatrist or prescriber. I'm going to refer you to our main clinic. The family goes to the main clinic, sees the prescriber there in person. I'm sticking with in person for now, and sees that prescriber. The main clinic bills, because that's where that's where it happened. They can also bill that enhanced rate because it was facilitated by the satellite clinic, right? It could be peer services at the main clinic and so forth. Just sticking with in-person for now. Did I understand that correctly?
Yeah, I think, yeah, and I think you hit the nail on the head with that, Boris, when it's facilitated through the satellite. So the coordination, that's the person holding the case, if that makes sense.
Right, so that's for in-person. And the same thing applies for in-person, I guess by appointment as well, I would assume, for the in-person component. What if, because some of the questions are like, summer months, holidays, schools are not always open, at 6 p.m. I know you talked about telehealth about 6 p.m., but what if, can an in-person session happen at a main clinic by the, satellite clinician, because that's when the family can come in. So there's all these kind of nuances that we're getting here, which I think fair to ask, because, schools don't have the 9 to 5 or 9 to whatever schedule.
Right.
So any thoughts there for the in-person component? Again, I want to be clear between in-person and telehealth.
Right, sure. So I think the big thing to underscore in the in-person, well, I guess universally, right, telehealth too, is it has to align with your OC approvals. So if your OC does permit you to do by appointment, then you can do by appointment, right?
Okay.
If it's only a 10-month school-based satellite, then if you're routing everybody back to the main clinic, you're not facilitating it through the satellite any longer through those summer months. So it does have to, I think that's the real underscore there, is that it has to align with your OC approvals.
Got it. So it's crucial for everybody, as one of the takeaways from today's presentation, is to go back to look at your OC and to see what it says there. Does it say by appointment? Is it a 10-month and so forth? And make sure that whatever works for you doesn't mean that you have to change it, but you might want to consider putting by appointment if you don't have it by appointment. Maybe it's more of a 12-month period and so forth. So it's important to kind of do that. Now switching to telehealth, we got a bunch of questions, of course, about telehealth. Again, like you said, I think you had a good example, meeting with the family at 6 by appointment, again, assuming you have that on your OC, makes sense. It's a collateral visit. Collateral visits are allowed. I assume you can meet with the family by themselves without the child, or a child could be present with that telehealth visit, right? Because we have 2 billing codes, so both are allowed. But you have to make sure you're following those procedures accordingly, because each one has it differently. So it's that's correct, because we got questions about, can you just meet with the family? I believe the answer is yes.
Yes.
And the same thing, I guess, and you said when the staff person is not on site, they could be at the main clinic or they could be home. But during the operating hours, as long as there is another clinician, because somebody should actually be there during operating hours, that other clinician can do telehealth and build the enhanced rate.
Yes, that's right. And I think, and that I think there's 2 things I want to highlight there. So I know we said it, but just in the darker purple section, this only applies when the student is enrolled in ongoing routine. So I just want to underscore that as the caveat when talking about telehealth. But then also another thing that I want to highlight is that we don't want to transfer responsibility to the school district, right? So if a practitioner, just to underscore what you just said, Boris, if the treating practitioner is offsite, maybe they're home for the day, right? Yeah. And the satellite's open. It's a normal operating day, but they're offsite that day for whatever reason. To transfer responsibility to the school district to then be responsible for furnishing their telehealth session, that's something we don't want to do, right? We don't want to be responsible for providing access to the clinic services. So it is still that requirement regulatorily that there has to be a clinic personnel on site during OC hours. So that's where, so it creates flexibility, but understanding that satellites are typically a one-person operation most often than not. So it's an allowance, but you still would have to have that additional staff.
Got it. And we did, and I know we did, it's not on this slide, but there is a question, and maybe further we're going to talk about, but since we talk about in-person telehealth home visits. I don't believe home visits count towards the, I mean, people can do home visits, of course, and they get 150% and all of that's still in play. This doesn't change any of that. But I don't think there's an opportunity to get this enhanced rate and the home visit. But just wanted to check.
I'll look to my colleague Gwen to triple confirm that that's accurate. Is that right, Gwen?
Yeah, that's right.
Yeah, so you would only, so if you're going off-site, you would, exactly to your point, Boris, you would be eligible for that off-site rate, which is 150% versus billing the both, right? Like it's one or the other, right? You can't bill both.
Okay. Yeah, I think we're getting a lot of questions, but we still have a more to cover, so we're probably going to move on.
Yeah,
one of the
Boris,
things. Yeah,
go ahead. Go ahead.
No. Go ahead, Shannon.
I will say, keep the questions coming, because one of the things and maybe this is what you were going to say, Boris, one of the things that we want to do is an FAQ document, because some of these things are nuanced, right? And they're situational. So we do want to be able to address your questions. So keep them coming. If we can't get to them or they're very specific questions, we do want to do an FAQ document.
Yeah, well, I'm just going to mention one thing and we'll move on. Again, because of there's a lot of questions about what happens if they go to the main clinic for our medication or peer services and so forth. They keep coming. So one of the things that Shannon emphasized, and I just want to emphasize as well, is that it has to be coordinated and facilitated by the satellite for you to get the enhanced rate if the family, the child, is getting services in the main clinic like medication or peer services or other type of services. What that means also is that has to be documented, that this was facilitated. Because if what you want to make sure is to cover yourself, that if anybody comes and says, show me how you facilitated, that, and it's just a note, right? I assume it'll be a clinician that works in the satellite clinic. They meet with the family, they have a session, the clinician recommends that the family sees a psychiatrist or prescriber, nurse practitioner. That should get documented. They get referred to your main clinic. From that point on, those sessions or that prescriber can get the enhanced rate because this, the clinician facilitated and coordinated that transition for those services. So again, just making sure that you're listening to this and translating this. What does that mean to you? What does that mean to your policies and procedures? And how do you document all of this at the end of the day? So I know we have many more questions here that we might have not answered. But again, as Shannon said, we're going to be looking to do an FAQ and we want to cover other things. So not sure it's back to you, Shannon or Gwen.
No, I'm gonna keep going. I'll be brief in the sake of time, because we do want to get to the commercial insurance side of the house too. So for services eligible to bill the school-based clinic rate, they must be, and this is exactly to your point, Boris, they must be rendered or facilitated through the school-based program, through the satellite program. There are new rate codes that have been established. They're here, 1030 for non-hospital, 1033 for hospital-based. They are only loaded in eMedNI or by location. The ZIP +4 for, excuse me, the satellite location, not the main site, must be used on the claim, which I think you were kind of alluding to, Boris, to receive the enhanced rate. If the claim for services provided by the satellite program are not currently using the ZIP +4 for the school, make sure that that is happening to ensure the proper reimbursement. Okay, so retro claims. So this, in case you weren't aware, this is retro. This 25% rate enhancement is retroactive to July 1st of last year, 2023. In order to receive the enhanced rate, excuse me, because these services, right, have already been paid by both fee-for-service Medicaid and Medicaid managed care plans. Claims adjusted using the rate codes will be necessary. So Gwen, by all means, jump in if any detail is needed, but a delayed reason code number 3 is needed for the appropriate code when adjusting the rates, the prior claims that were submitted, and then eMedNI programming will temporarily pay the DRC3 coded claims without pending for review or requiring further information. So this is, I think the big thing here is that action would be needed by a provider in order to secure those retroactive. It's not going to be an automatic process.
All right, so I'm just going to jump in here because there's some things that Shannon talked about, but I just want to add. So a crucial component here is the last bullet. The adjustments are not automatic, right? So this does require that every satellite clinic look at their billing that goes back to July 1st of 2023. If you're interested in receiving enhanced rates for that period, I assume you all are, and that you will need to resubmit or bill again, for adjustments to your claim. So what that means is, I'm just going to go back for a moment. You need to make sure that ZIP plus 4 is included when you're doing this, that you're using the new rate codes when you're rebilling, right? Making sure that you need the claim to be adjusted with that enhanced rate, but that also, not only are you including the rate code and the ZIP plus 4, it's also important that you indicate on the claim that this is an adjustment. And usually it's part, and if you look at our billing tool, at the MCTAC billing tool, it's a belief field 4. We talk about claim type. And claim type, if I'm not mistaken, should be 7 when you are billing for an adjustment. One of the concerns that I have, that if you're not using appropriate claim adjustment billing, that you will get denial saying that this is a duplicative claim. So again, important that you follow the right protocols when you are adjusting your claims and you're rebilling, that you're using rate codes appropriately, ZIP plus 4, but also indicating that you're actually submitting this claim as an adjustment. So this way, both the managed care company and fee-for-service Medicaid knows that you're not just submitting a duplicative claim, because again, if you don't do that, you will get most likely, not always, but most likely a denial saying that this is a duplicative claim. So just wanted to emphasize that again. We'll encourage folks to use our MCTAC billing tool. There's additional information. Sometimes, again, depending on managed care company, you might need to include previous claim number on it as well. So the managed care company knows which claim you're adjusting. It's easier for them to match that as it relates to this. So you want to make sure that you're following that, because this is not going to be automatic. And you also need to make sure that you go through your services to also make sure that they follow the rules that Shannon talked about when the enhanced rate is applicable, because there may be situations that the enhanced rate was not applicable, and you should not be then resubmitting a claim for that adjustment. So it's a little, it takes a little, will take time, but this is where temporarily those codes you have for fee-for-service and also managed care will be accepting these claims. So there's a lot here. So again, yes, the managed care, I think, Gwen, correct me if I'm wrong, just to repeat, will be temporarily waiving the timely filing, but not forever, right?
Right. Yeah, that's on, I think it's coming up on the next slide.
All
but
right.
I just want to mention on this slide that there were a couple of questions that I see coming up on the side about the delay reason code 3. This was just implemented. So if the DRC3 did not work previously when submitting fee-for-service claims, it will work now. So starting today, you could go back and click on that.
Excellent. Thank you for clarifying that, Gwen. All right.
Mhm.
I know we have questions again. Hopefully we'll be able to come back and answer, but let's keep moving. We'll go to the next slide.
Should I jump in?
Sure. Thanks, Gwen.
Hi, my name is Gwen Diamond. I'm the Director of State Plan, Finance, and Data Analytics here at OMH. Just jumping in here on the billing and claiming considerations. On the managed care side, the plans were notified of this change back in November. They're preparing their systems now. I see some of the comments that managed care is saying that they're not ready yet. They are not required to begin paying those school-based enhanced rates until February 15th. We give them 90 days. We notified them in November. The plans must pay the enhanced rate retro to July 1. And again, as we've been talking about, to receive the increase for claims already paid, the claims are going to have to be adjusted. And what Boris just mentioned, the plans have agreed to waive the timely filing requirement for those school-based claims. Next slide. Okay, so we needed your help, so your provider input and assistance. We sent out letters back in November to all MHOTRS programs listing the school-based satellite locations with a request for review. So they were provider specific. They had a list of all of your school-based sites. If there were any issues, we were asking that you make corrections. So if there were problems with the listed locations, then that is something that the provider needs to change in MHPD through an administrative action. And if we were missing a school-based location, we asked that you contact us at the email address listed for help. If you didn't receive this letter, you can send an email to the Medicaid fee-for-service billing help and just make sure that you have your clinic name and MPI, and we can go back and forward the email to you. It was sent to the emails that we have on file in our licensing unit. So that's who would have received our letter. Okay.
Okay. All right. So shifting gears slightly, we're still talking about school-based satellite clinics, but now we're going to talk about commercial insurance. Next slide, please. Okay, so just a little bit of level setting context. So hopefully everyone on this call is aware there was an amendment to the insurance law that occurred last year, but went into effect as of January 1st of this year, 2024, that requires insurance plans to provide reimbursement for covered outpatient care when provided by school-based satellite clinics, regardless of whether that program participates in the issuer's provider network. I know that's a lot to unpack, but just want to make sure that, pause between those very impactful elements. Additionally, the reimbursement, and this is also very critical, must either be at the rate negotiated with the provider or in the absence of the negotiated rate. And we'll talk a little bit more about this in detail in the next few slides. Then an amount no less than the Medicaid rate, which we're going to refer to as government rates, must be applied. This amendment to the insurance law does not apply to Child Health Plus and Medicaid managed care coverage. So that's a little bit of the background of what we're talking about here. Next slide, please. Okay. So what does this mean to you as a school-based satellite clinic provider? So insurers are required to comply with this reimbursement mandate beginning when the contracts renew on or after January 1st. And we'll talk a little bit about that. So this means that some plans will comply with this mandate, right, as of January 1st of this year, if the plan renews on a calendar basis, right? If it renews on the beginning of the first of the year, then that's when it would be applied. Others renew at different points of the year or later, and that's when it would be applied for those specific circumstances. The effective date of these provisions is dependent upon the renewal of the member's policy. Therefore, the APG rate reimbursement requirement may become effective at a later date for out-of-network school-based satellite services. Next slide, please. Okay, so if you're a visual person, I think this breaks it down a little bit more. So, right, so some individual policies might renew on an annual basis. So come January 1st of every year, they might renew, but there are circumstances where that might not be the case. So if we look at the first arrow, so for providers that are already participating in a planned network, right now you're participating in a planned network, the rate is the prior negotiated rate, unless or until the provider renegotiates the provider agreement or stops participating in that plan. For the second arrow, for providers that are not participating in a planned network, the plan must pay at least the government rate, the Medicaid rate, unless or until a negotiation is finalized. So I think those are two important distinctions to call out. Next slide, please. Okay, I'm going to kick it over to Gwen for the next little bit.
Thanks, Shannon. So to continue with that last slide, this reimbursement mandate applies to all policies, regardless of whether the policy or contract covers out-of-network benefits. And out-of-network authorization is not required. Next slide. This law is applicable to New York State fully insured plans. Self-funded plans are not required to comply with state laws. And also, if a New York resident is covered under a plan that is sold under another state, that plan is not required to comply with New York law because it is subject to the laws of the state where it was issued. Okay, so now what should you do next? As I said, we had sent out the list of school-based locations. You should confirm that that's accurate, including the agency name, the location, address of the school-based satellite, including the zip +4 and the MPI. If you don't have the letter, you can go to the link shown below. This link was also provided to the commercial plans so that they would have a list as well. And we're continuously updating that list for if there's any inaccuracies. We've been updating it pretty much on a weekly basis. But you can visit that site and check and make sure that all of your locations are accurate. And any missing locations, send an email to Medicaid fee-for-service billing help. If all the info is correct, you can start billing. I do want to mention that we have some locations that have not been loaded yet. We're working on it with eMedNy. And once they're loaded, you will receive notification that those rate codes are active. And I also just, I was looking at some of these comments, and I just want to mention on some previous slides, when we talk about going retro to 7/1, that is not required. If you have already been paid billing the regular APG rate codes, for example, 1504, and you do not want to go back and adjust your claims, you don't have to. You're only going to do it if you would like, you want that 25% enhancement. I know that there were some people that were concerned that we were requiring that, and it would be a big lift for some. So I just wanted to make sure you understand that. Next slide, please.
Right.
And Boris.
Yeah, thank you, Gwen. So again, just a couple of things to repeat and emphasize before. Should I negotiate new rates? What should I consider? And I know we got a bunch of questions actually asking these questions, so we kind of foresaw those questions coming. So again, this does not apply to every commercial plan, as was mentioned. I know in the chat there is a link to a DFS. So thank you for the person who put that in. We'll include that in our resources. And because one of the questions was, is there a list of who's self-insured, who's not self-insured, and so forth. So clearly that's one of the major consideration. And for those folks who are already in network, something that you need to consider. But just to repeat, if you have a negotiated rate, that's the rate you're going to continue getting paid, even if it's below the Medicaid rate. It's only required by the commercial plans to pay you the Medicaid rate if you're out of network, or of course, if you were able to negotiate that rate. And as many people mentioned in the chat, that they don't, the plans don't negotiate to that level and so forth. So one of the things you should think about, and again, when you think about managed care contracting, yes, we're talking about, satellite based mental health clinics, but of course, those contracts probably apply to all of your clinics. And so one of the things you need to think about, what will that do to some of your main clinics and so forth. But right now, this law only applies to the school-based mental health clinics, right? The satellite in schools, and not just general. So some of the pros, right, of what you can do, if you stay as is, you get direct pay, because when you get out of network payment, it could be, and we'll talk a little bit about it, there's good chances that it goes to the family, which then the family has to pay you. And again, we'll talk more in coming slides on it. You'll continue to be listed on the network, so you can get more referrals. There's potential reduction in process, and this is if you negotiate and stay in network. So there might be some benefits, even if some of the commercial plans get into value-based payment or other types of arrangement. By staying in network, of course, you need to panel your clinician. There's a credentialing process that's usually involved. The rates, as everybody has mentioned, I think, are much less than Medicaid rates. And so that's definitely the huge, con against that. And there's always those best practices for negotiation. But again, those are very hard, as we all know, to negotiate high rates in the commercial world. But you can still try and kind of think about it. And you can always limit the contract arrangements, right? So the question is, can you say, look, I'm going to go, if you're in network already, that maybe you consider going out of network, right? And try to negotiate that only your school-based mental health sites will be out of network, keeping your main sites in network. Not all plans will like that or be willing to do that, but that's something you can try to negotiate and see if that works. And if you go out of network for your satellite, again, you'll be getting paid at your at the Medicaid rates at that point. So each organization has to think through what's the best approach to them. It doesn't make sense to continue staying as in network. There's many factors that go in. Doesn't make sense to maybe go out of network at this point to get the Medicaid rate, which has its own pros and cons to it that we'll talk about. And for those who are out of network currently, to think about what that means to you as well. So lots to kind of think through. So what should you do next, right? If you choose not to negotiate, one of the things is you want to make sure that you're always keeping your insurance information collection, the intake process, your Medicaid rates minus the in-network cost sharing. And again, important to highlight here, if you stay out of network and the Medicaid rate is paid, because that's what would be required, the plan will follow the in-network cost sharing. So what does that potentially mean? Again, there's so many variations. So this could be one of many examples. So if a family has an in-network cost sharing, or also sometimes referred to as co-payment of $40 per visit, the family will still need to pay you the $40. The Medicaid rate will apply, and the plan will pay the difference. So if the rate, just making it up, so if the rate for a particular visit is $100 and the copayment was 40, the family would need to pay you 40, and the insurance company, the commercial plan, will pay you 60 in that instance. So the in-network rate, and the good thing about it, because if this was out of network cost sharing, we all know that those dollars will be much higher for families, and not all families have out of network benefits. So the nice thing about here, it only follows the in-network cost sharing, and it's irrelevant at that point if the family has out of network benefit, because again, it's all about in-network. How would you get paid if you stay out of network and don't negotiate? So most of the time, we have 3 examples here of facilitating it. The payment goes to the family, the patient, the family, and so forth. It could be the provider bills the family. So one option is you bill the family sends the bill to the plan pays the family, and then the family pays you. The other option is, again, you bill the family pays you upfront, and then the family sends the bill, the family gets reimbursed by the plan, and that kind of ends it there. The third option is the provider gets cost sharing, meaning you collect, in my example, the $40. That's the copay of the in-network. Provider bills the rest, the $60, again, back to my example, to the plan, and the plan pays the family, and then the family pays you. In this instance, you bill them directly. There is a fourth option that we don't have here on the screen, and again, you would need to work with the family and the plan to work this out. There are options where the plan pays you directly, and you need to work or find out if that's an option and if that's possible. So in that scenario, you would collect the copayment of $40, build the plan, and collect the $60 directly from the plan. And at that point, the family would not be involved in paying you back. So again, there's a lot to consider, but at the end of the day, just to highlight here, if you're currently working with commercial plans and you already are in network, these scenarios that we just provided really are not changing from what you currently do. So whatever your current policy and procedure are as it relates to commercial plans, kind of who pays, who bills, and so forth will remain the same, right? If it's a family collecting and paying you, if you're billing directly, if you collecting money up front. So we're just giving you some of the scenarios, especially those who haven't been working with the commercial plans, to give a sense of what might be happening. The big change is really the rates that are changing for those who are out of network in that respect. And so making sure that for those instances, you're getting paid appropriately. But in regards to the general commercial processes, meaning collecting co-payments, who gets paid, who pays whom, and so forth, are basically staying the same. This law doesn't change that process as it relates to this. Okay, so what should school-based mental health clinics do next? So one of the things you want to make sure you're assisting and educating families, you're working with schools, right, and making sure that the school system understands it. And I would say there's 2 things that you need to think about. And we're also going to be working on creating a toolkit, additional resources, additional support. So look out for those forthcoming. I see this as one, you're going to need a kind of, I'm going to say marketing or some sort of informational one-pager to inform families and schools, just as a general kind of, what if you have a commercial plan, what might happen? The other one, and again, if you're already working with commercial insurance, you should already have these policies and procedures and these documents in place. You should have some sort of a letter or form, I would say, that the family understands, and you explain that to them during the intake process or whatever your process is in regards to bringing in new families into treatment and into your clinic, in regards to what that means, right? So important for the family to understand about what plan they have, if it's fully insured, if it's out of state, they're making sure they have the policy number and so forth, and also making sure that they assignment of benefits, meaning that they're signing off and they're assigning the benefits to you. And again, If you've been working with commercial plans, I suspect you have this, or you should have this at least, in regards to how you work with managed care organizations and insurance in general. One of the things we'll be working on is potentially putting together a template. So for those who haven't worked with commercials in the past, or are not working currently, could use this template, and also some of that kind of a checklist marketing material. But again, wanted to highlight some of the things you should be thinking about and making sure that you're reviewing currently, and maybe you need to review some of your policies and procedures that you've had in place as well. And as we continue with, what should school-based mental health clinics do next, is again, educating families, providing information about the community health access to addiction and mental health care project, CHAMP. So there's also that piece that's important. And CHAMP operates a statewide helpline and partners with local organizations in order to help anyone facing issues accessing care of their insurance, of course, including patient caretakers, providers, families, and so forth. These services are free and always confidential. And when you get these slides, and again, we will be distributing the slides and these recordings, so you'll have all these links there as a resource. So call every time you have an insurance issue. So if you are having problem, especially for family that's having problem with their insurance, they should call CHAMP and have a discussion with them as well. So as I mentioned, we already have some resources here. We're going to keep adding. We got some through the chat, so thank you for those who included it. And we're going to be building these toolkits and additional resources forthcoming for you as well. So with that kind of completes our formal presentation. As I said, we're going to have some time. We have 10 minutes left for Q&A. I know there, in the corner of my eye, the chat just kept coming. So one, I'm going to turn to Gwen and Shannon to see if there was any other questions before I start looking through them that you wanted to address as I start scrolling through them myself. So please feel free to jump in and start, addressing any of the questions.
Boris, can we go back to the previous slide?
Which in particular?
No, just the one that had the resources.
Oh, the resources.
Mm-hmm. Yeah. Okay. So the second link about the commercial plans, I just want to reiterate, because I'm seeing on this through the chat, how will they know? How will they know which locations get the enhancement and that they're school-based? All of those addresses, MPIs, ZIP+4, title, they're all listed at this website or at this webpage. So the plans have been instructed to use that file to know that they're required to pay the government rates at those locations.
Excellent.
And just to level set, I'll take the low-hanging fruit, Boris and Gwen. I just want to reiterate, this is being recorded and the slides will be made available. Also, if you have questions today that we didn't get to, or the questions we did get to, and it's just nice to be able to reference them in writing, or if you think of questions after this, after you've had a moment to digest it, please send these questions to us. We do want to create an FAQ, and something that we didn't mention at the beginning, which I think is really important. This is just one facet of resources we want to provide to you. This is a lot of information, and there's a lot to consider here. So this is just kind of, for lack of a better term, like kind of a kickoff, right? We're kind of referring to it as a toolkit. Boris had alluded to a lot of resources that we're going to be creating, templates, forms for you to use, but also just resources so that you have a place that you can reference some of this information. So more to come on that. This is kind of the beginning, so to speak. Yeah. So I want to highlight that as well.
Yeah, no, thank you. So again, well, I know there's a couple of questions. So I just wanted to come back to the out of network piece. So if you are out of network with the commercial plan, that falls into, again, it's not every commercial plan, but that falls into this new law. it doesn't matter if the family has out-of-network benefits or not. The plan has to pay you the Medicaid rate, and they will apply the in-network benefit when they pay you. So the even though you're out of network, and I know it might not, might not sound as a usual process, because it's not, right? Because usually if you're out of network as a healthcare provider, the family has to have out-of-network benefits. You have to deal with out-of-network issues. The co-pays, co-insurance are all different, and so forth and so on. That is not the case here. If you're out of network for school-based mental health, what happens in that instance is the plan will pay you in-network at a Medicaid rate and apply the in-network rate. So again, in my example that I used earlier, if the copay for in-network benefit for mental health services is $40 and the Medicaid rate for that service you're providing is $100, the plan will pay you $60 and the family still owes you $40. And even if they don't have out-of-network benefit, that will still apply and go forward, which I think is a wonderful opportunity, right? Both for families and youth and individuals to get the service and not worry about do they have out-of-network benefits and so forth. So just wanted to highlight that in that instance. And some of your negotiation with these commercial plans should be, a discussion about current rates. Are they willing to pay you the Medicaid rates while in network? What happens if you go out of network, and so forth, and have that discussion with them, because again, you also want to make sure that if you do decide to go out of network and you're currently in network, how it impacts your other programs, like your main clinic and so forth, and other things, how it might impact. And again, this would not apply to all plans. And it's important to highlight that it's not even at the insurance level, right? So I'm going to use United Healthcare as an example, but it could Anthem, it applies to all plans who, Aetna and so forth. It's not about just United Healthcare or Aetna or Anthem. You have to dive into the plan that the family has, because each of these companies have 50 different plans. Some might qualify for this and some might not, because depending if they're self-insured or not self-insured, as one example. So that's one of the things you need to consider when you are going through this. All right, Gwen, I know we have a couple of more minutes. I'm just scrolling through.
I just had one other quick thing to mention, just to reiterate that if a child has commercial and Medicaid, of course, you have to always fill the commercial first. Yes. Question that came through.
No, thank you. And Gwen, I think there was also a question about New York State Empire Plan. If I'm not mistaken, that's the New York State Employee Plan. Even though it's self-insured, I think they agreed to pay the rate, but I just want to turn to you, Gwen, about that.
Yes, and that was included in the slide.
Excellent. Yep. So just wanted to confirm that if you are, and I know some of you do serve a decent amount of individuals who do have the New York State Empire Plan, even though that particular plan is self-insured, they have decided to follow this new law and will be paying the Medicaid rate if you're out of network in that instance. Okay.
I just wanted to mention one other answer to a couple of questions.
Yeah, please.
One of the questions is, how do we identify to the commercial plan that the service was school-based mental health if we don't bill with the rate code? It's all based on ZIP+4. It's the billing address. In order for the plans to know, they're using the list of all of the school-based locations and matching that with the claims. So you must use the school-based locations ZIP+4.
Excellent. So Gwen, if anything people walked away with today, ZIP+4, both on the rate adjustment and billing for the commercial. I mean, there's much more than
Mhm.
that, but I think that's a crucial component for both parts of today's presentation.
And
Yep,
and
you're
Laura,
right.
I'm sorry, I can just I missed a couple of minutes in the beginning. But just to reiterate, that's why, we sought all this inaccurate information from you about where your school-based mental health clinics are located. It wasn't just about processing, the rate codes in Medicaid. The state provided information regarding your school-based mental health clinics, extensive information all the way through ZIP+4 to the Department of Financial Services to provide to plans so that they know who you all are.
No, thank you for that, Jessica. I do want to just emphasize, I know we said it earlier because we're getting a bunch of questions. The reason this does not apply to Medicaid or Medicaid managed care or Child Health Plus, because those already pay you the Medicaid rates. And so because those rates are already in place, you do, have to be in network with them to receive those rates. But those rates are already in place, and there is really, I mean, you can try to negotiate a higher rate. Not sure how successful you're going to be there, but for Medicaid managed care and Child Health Plus, and again, Gwen and Shannon, correct me if I'm wrong, they already have to pay you the state approved rates, but you do have to be in network. I assume that's accurate, Gwen?
Yes, that's correct.
All right. So I think, I just want to say thank you to our OMH partners for this presentation. As we said in the beginning, we know there's going to be a lot of questions. We appreciate all of the questions that have come in. We're going to be looking at, not just as we've said, putting together, sending you these presentations, of course, in the recording, but also putting together potentially an FAQ document, but also, as I mentioned, expanding our resources and putting together a toolkit. Please keep those questions and comments coming as we move forward with both of these, the rate enhancement and the commercial implementation. So I don't know if Gwen or Shannon have any last minute comments before we close off today's session.
I don't think so. I just appreciate everyone's time. I know this is a lot of information, and as Boris said, we'll have more resources coming. I don't know if it's possible, Boris, to scroll up to the top where there was an email address for folks to email, in the interim after you've had a chance to digest this and you have more questions. I think it was at the top, maybe. Oh, here we go. Oops, sorry about that. Yeah, here we go. So we can compile questions to inform the FAQ